Good evening, everyone. My name is Dr. Aneez, and I'm speaking to you from Singapore. This is a great opportunity to talk to all of you through the web because we can't do it in person. This is also a wonderful opportunity presented to you by the Southeast Asian Thoracic Society, which is a purely dedicated educational platform for thoracic surgeons, not only surgeons, but also for all the trainees and people who are associated in the field of thoracic surgery. So today we have two excellent speakers who have their own niche. So I'm going to introduce the first speaker. It is Dr. Harish, who's my colleague from National University Hospital of Singapore, who specializes in minimally invasive thoracic surgery and thoracic oncology. Uh, he's developed very good interest in handling tiny nodules and GGOs. And without much further ado, I will let Dr. Harish get on with the webinar.
Great, thank you for the introduction, Dr. Aneez. I'll just start with my sharing my screen. And just give me a thumbs up if you guys can see it.
Yes.
Okay, excellent. Okay. Very good evening, everybody, and thank you for signing in to our I think our fourth seats meeting today. And I'd like to thank Medtronic for sponsoring this event. So what are we going to speak about? I'm going to speak about today's management of pulmonary nodules and GGOs, and whether interval scanning and versus localized diagnosis. So there we go. Okay. So the areas I'm going to touch about basically is definition of the nodules, workup, understanding the CT morphological features, and only from then we can go on to management and follow-up of these nodules. So basically, what is a nodule? A nodule basically is something we see on the CT scan, and it has to be under 3 millimeter in diameter. It should be well defined, and a nodule must be completely surrounded by lung parenchyma to actually define it as a nodule. And of course, there has to be absence of effusion and atelectasis. So anything more than 3 millimeters in size is considered a pulmonary mass, and we're not going to talk about that today. So when you see a pulmonary nodule, you can actually classify it. The BTS guidelines classifies it in two main areas. The first one is a solid nodule, and another one is a subsolid nodule. And a subsolid nodule actually is then divided into either a pure GGO or pure ground glass nodule where it doesn't have any solid component in it, or a part solid nodule where you have both the ground glass and the solid component. So when you define a solid nodule, the first thing you have to notice that it actually obscures the bronchovascular structures. So it's purely solid, and the bronchovascular structures behind it is completely obscured on the CT scan. Whereas for a GGO, if it's a pure GGO, you can see here, it does not obscure any of the bronchovascular structures. And so the opacity is just slightly more than the background. And of course, the subsolid nodule has a combination of both a solid component together with a GGO component. So of course, we know the etiology. We can list down, we generally define nodules as benign or malignant. And these are a few common ones. But if you were to exhaust the list, you can go online, you can see the list is actually very, very exhaustive, and you can actually classify it according to multiple areas. So before we decide what to do with actually the lung nodule, whether we should do surgery or whether we should follow up the patient, there's a few characteristics we must know as thoracic surgeons before we make any decision. So there are 8 main areas from a CT scan that we should keep in our mind every time we actually decide. The first thing we look at is the size, the location, attenuation, the shape and the border, its growth, its calcification and fat, whether it has any cavitation, and of course whether it's enhancing with the contrast. So I'm just going to touch very briefly on these 8 main things. So the first thing is size. So basically the size, we know, is kind of an independent predictor for malignancy. And we should actually measure the average of the long and short axis, and we should round it up to the nearest millimeter. And we should look at it actually in the lung window, because if you just look at it on the meter tunnel window, you only see the solid component. But when you look at actually on the lung window, you measure it based on the total length of the GGO. 1 mm cuts are the most reliable to define it. So as the nodule gets a bit more bigger, the risk of malignancy actually increases. So as you can see here, if it's under 5 mm, it's a risk of 1%. And of course, larger lesions can go up to almost 50% risk of malignancy. The second thing we need to look at is generally, if you're thinking of a cancer, central lesions are generally placed, which generally will be either squamous cell or small cell. A peripheral lesion generally will indicate maybe could be adeno or a large And equally distributed lesions can be either be benign or even a metastatic disease. Another thing, the third thing I said is attenuation. So like I mentioned earlier, it's about whether it's a GGO, it's got a solid component, or part solid, either a purely solid, or is it a part solid, or is it purely GGO? So this is very important because on the follow-up pattern, GGOs and part solid GGOs are actually the most important thing to follow up. Another thing we look at, if we look at the shape of it, of course, if it's round and oval shape and it's well defined, generally kind of points to more of a benign disease. But sometimes scars or atelectasis also can appear like this, where it looks linear and irregular and angular in shape. So it's something we actually need to define and watch that a bit closely. Now, carcinomas, I think if I wake everybody up in the middle of their sleep and show you the scan, immediately I'll say, what is it? And then you'll say it's a spiculated lesion. So generally, malignancies have what we call the corona radiata sign. And basically, it's the growth of the malignant cells along the pulmonary interstitium. But you still can have about 25% of lesions that are benign. So that's why it's good to actually get a complete history from the patient and understand a little bit better before making a decision. How about growth? So growth is very important for us to understand this. If you're following up a CT scan, any lesion that actually increases, a solid nodule that increases more than 2 millimeter in size is something that you should turn an eye to, and you should consider getting some histological diagnosis. What about if it's a subsolid lesion? So if it's a subsolid lesion, what you want to do is, if there's either increase in attenuation or basically increase in the solid component, is something you should also keep a close eye and a watch on it. How about volume doubling time? So we see like, okay, someone presents a scan to you in the emergency, they do a CT scan, maybe part of a trauma, and they find out, okay, there's a lesion there, and then they had to get a repeat CT scan within 2 weeks, and you see this lesion growing very quickly. Very rarely will actually that be a malignancy. So basically, benign lesions generally have a volume doubling time of about under 20 days, or can be more than 2 years. Malignant lesions generally have a doubling time between 20 to 400 days. And one caveat is, of course, the carcinoid or pre-invasive lesions generally take a very long time to grow. So not everything that grows, you must understand, is cancer. And this is a nice diagram over here that shows that under 20 to more than 400 days is something you should actually keep that in your mind and think about it. So here's an example of a benign lesion that's been followed up for almost about 12 years. You can see the lesion here was small, gradually progressed to a larger size, and then on the PET, it wasn't PET avid at all. So how about calcification? So calcification is kind of a clear indicator for us that actually this can actually be benign lesion. So generally we have multiple patterns of calcification. You have the diffuse, the central lesion, the popcorn appearance or concentric appearance, and these kind of guide us to what we think is maybe more of a benign lesion. But what we must look out for is for ground glass appearances or eccentric lesions, which actually can indicate a malignancy. So here's an example of a central region over here. It's quite clear cut, and it looks very much benign. And again, here it's a classical granuloma kind of a feature. But eccentric classifications, things like this, is something we should actually really consider doing a biopsy and taking a look at it in further detail. So the 6th point out of 8 points basically is the presence of fat. So what about fat? So when you usually see fat within the lesion, it kind of points to you most likely to a pulmonary hematoma. There are rare occasions that you can get metastatic liposarcoma in the lung, and they actually have a fat component within it. The 7th out of the 8 component we look at CT scans is basically cavitations. So cavitations are very common. We see it in squamous cell carcinomas, but also we see it in a lot of benign diseases. So it's something to look for and think about. So when you look at the thickness of the cavitation, it's something that can guide you to what you should do. So if the wall thickness is under 4 mm, it's most likely like a benign lesion. The wall thickness that is very thick, more than 16 mm, kind of points to a malignancy. And of course, you always sit in between the lesions where it's 4 to 16. You're wondering, okay, what is this? Another thing you want to look at, I'm sure you see this a lot. This is the crescent sign. So if you see a cavitation lesion with a growth in the side, this is kind of classical for aspergilloma, and of course you have to do something about it, but it kind of deviates away from the malignancy point. Of course, air fluid level is kind of an indication for infective causes. And the last thing, the most important thing we want to look at, not the most important thing, one of the last things we look at is enhancement. So malignant lesions generally, they enhance more because why? The arterial supply of most malignant lesions come from bronchial arteries, and the drainage actually comes from the bronchial veins. Now, most of the time when the lesion actually expands and gets bigger, it actually blocks off the interstitial space around it. So therefore, when the contrast goes in, it kind of retains over there. For benign lesions, generally the interstitial space and lymphatics are not blocked, so actually they don't enhance very much. But of course, things that are benign like AVM, of course, is a high contrast enhancement. And infective lesions, the problem in infection is that it forms a fibrosis layer around the lesion. So that's why the drainage actually doesn't come out very much. That's why the lesions tend to enhance more. And the last one, of course, air bronchograms sign. This is kind of obvious that most likely will indicate a malignancy. So once we look at the CT scan and we decide something, what should we do? We're sitting in the clinic and we decide, okay, what is the prediction of the malignancy for this lesion? So there are many predictors out there. And, we have the Mayo Brock predictor, the VA predictor, the Herder's prediction tool. So, but mostly many people actually use the Brock predictor. And generally, they have a few points over here. You can actually key it in online. And these are based on odds ratios. And it creates a result for you and gives you a cancer probability. So if the lesion has a low probability, it's under 5%. Over here, it'll give you the cancer probability. If it's intermediate, it's between 5 to 65%. And of course, if it's a high risk, it'll be more than 65%. So with this data that you have in mind, you can then decide what to do with this patient. And so what should you do? Should you follow up the patient? Should you biopsy the patient? Should you just go straight up and resect the lesion? Something small like this. So it kind of, all these models kind of guide us from the CT scan appearance to the predicting models. It kind of guides us on what we can do. So there's a lot of guidelines on follow-up. Again, there's the Fleshner guideline, there's ACCP guidelines, there's the Lung Reds guideline. I think many of us here kind of use the Fleshner guideline. And if you look at this chart over here, it's really, really busy. So I tried to find the simplified version of it, and you can see here, if the lesion actually is a solid lesion, and you see a clear-cut solid lesion and it's under 6 millimeter in size, and they are low risk, generally you don't need to follow the patient up. If they are high-risk patients, generally under 6 mm, they say optional CT scan at 12 months. But I think most of us as thoracic surgeons, we are more, I wouldn't use the word paranoid, but I think we're more concerned when it comes to any lesion in the lung. So generally, most of us will follow the patient up with a repeat CT scan. The patients that are between the 6 to 8 millimeter size is the ones that we always kind of decide, what should we do? Should we go in and do a biopsy, or should we follow the patient up? So if you're following up the patient and it's a low risk patient, you can do a repeat CT scan at 6 to 12 months, and then you can consider a repeat scan again to about up to 24 months later. If it's a high risk patient, generally I would repeat a scan. 6 to 12 months is recommended here, but I generally do an earlier scan at 4 months. Now, if it's more than 8 millimeter, then generally for us thoracic surgeons, it's kind of a no-brainer sometimes, and we will generally be more aggressive with these 8 millimeter lesions. Now, if they're low risk, you can give the option of follow-up CT scan for the patient, and you can see even the Fleshner guidelines tells you to follow up more closely at 3 months. But if it's a high-risk patient, generally you would then consider going and doing a biopsy or a resection. Now, what happens if you have multiple solid lesions? So generally, again, under 6 mm, you have no routine, and if it's more than 65% high-risk patients, you generally want to do a repeat CT scan. And if it's more than 6 mm, generally, I would focus on the biggest lesion that is present over there, and then I would definitely repeat a CT scan for them in either 3 to 6 months. And if it's high risk, I would then suggest a biopsy for the patient. So what about GGOs? So GGOs are the ones that actually are more important for us, because the GGOs and subsolid lesions are actually, they have a very high risk of them being malignant too. So for solitary pure GGOs, under 6 mm, you can see here, no routine follow-up, but they consider, they comment, they say that, look, let's maybe you can repeat a scan in 2 to 4 years time if they have a low risk, if they have low risk. But if high risk, then you go back to the basic follow-up thing. So if it's more than 6 mm, then generally you want to repeat a CT scan from them. And again, their comments are here. Histological sampling requires resection, as GGOs are not amenable for needle biopsy. So generally, if you want to follow them up and you repeat a CT scan 6 months later and the lesion is still there or it's gone a little bit bigger, generally they recommend a pure GGO be resected. Now, how about for the part solid lesions? So again, if they're under 6 mm, no routine follow-up again. but more than 6 mm with a part solid GGO, again, CT scan at 3 to 6 months, okay, to confirm the persistence. So Jenny, if they're unchanged, again, they recommend basically annual CT scans for up to 5 years to make sure nothing grows. If there's anything more than 8 mm, then you should suggest going for histological sampling. For multiple, it's the same concept again. I generally will pick for focus on the largest lesion and follow up that lesion. So once the lesion becomes large, more than 8 mm, now this kind of like opens our eyes straight up and we say something needs to be done. So the Fleischner guidelines give us many things, but if you look for VATS wedge resection, the recommendation journey, there's more pluses on this side to actually go in and biopsy the lesion and to have a complete resection. So you not only get therapeutic, but it's also not only diagnostic, but it's also therapeutic, the resection. So you remove the lesion, so you don't need to follow them up so much. And if it's benign, great. But if it's malignant, then you get a diagnosis, and then you can actually decide on what next to do. So once we followed up, once we've decided, okay, we're gonna go ahead and we're gonna go and biopsy the lesion, what should we do? What are our options available? So we've got non-surgical biopsies where we can do either bronchoscopic biopsy, and these are generally done by respiratory physicians here in Singapore. And then you got the conventional, you got the bronchoscopic transbronchial needle aspiration. They have their EBUS, and then now newer technology, which I'll show you later, is navigational guided transbronchial biopsy. And of course, most of us actually send our patients also for CT guided transthoracic needle biopsy. And of course, the surgical biopsy will be straight up. Either you do open or a VATS and resect the lesion. So for bronchoscopic diagnostic results, basically, generally bronchoscopy biopsies are done mainly for more centrally located lesions. And you can see here their yield is about 73 to 85%. But with navigational bronchoscopy, the yield is actually getting better and better. And I'll touch on it a little bit later. So CT guided biopsy is quite straightforward. We send the patient to the radiology department, and our interventional colleagues over there will then perform a CT guided biopsy. The yields are quite high, more than 90%. There's always a 10% chance that they don't get a yield, but 9 out of 10 is a pretty good yield. And generally, they even can hit the target generally if they are under 1 centimeter in size. So most of the time when we counsel our patients in the clinic, we tell the patient that when you go for a CT guided biopsy, there's always a 10% risk of pneumothorax, but only about 10% of those who actually get the pneumothorax will actually need a chest drain inside. And of course, there's always a risk of bleeding, but most of the time, the bleeding will come from hemoptysis. They may get mild amount of hemoptysis, so tell them not to worry. And generally that will resolve in a few days to a week or two. So now we decide, okay, what to do, so we said, okay, they say it's not amendable for bronchoscopy biopsy or not amendable for CT guided biopsy. What's our next option? So those days, or even now, some people still do it. They do the standard surgical approach where we do a thoracotomy for the patient. And then with the CT scan guidance, we manually palpate and identify where the lung nodule is, and we resect it. But of course, since the introduction of VATS in 1990, we've gradually gone from what we call the big thoracotomy or futile thoracotomy to more smaller and smaller cuts. And this has made the ability for us to biopsy lung lesions more, the word is rewarding, or the physicians actually send us more because it's less invasive right now for the patient. So of course, the standard approach, you've got the 4-port VATS, we have 3-port VATS, we have 2-port VATS, and of course now many people are doing uniportal VATS for this. But the idea basically is that how do we go and tackle the lesion is what we want to know. So if you get lesions that are very, very peripheral like this, you don't need to do, you don't need any assistance at all. And Jenny, when you put in your scope, you can literally see the lesion over here. You can even palpate it with your ring forceps, and you can get a tactile feedback, and you roughly gauge how deep the lesion is. And sometimes these lesions, you can even through the VATS incision, you can put your finger in and you can palpate and confirm the location. But what happens if the lesion is not palpable, or it's very close to vital structures? So again, I think Prof. Mann will be talking about segmentectomies, and generally you can then localize the lesion by a segmentectomy and perform it, do an anatomical segmentectomy to resect it. Now, what about these lesions? So these lesions are not too deep, sorry, not too superficial, but not too deep. And generally, you don't want to do a segmentectomy for these kind of patients, especially if it's just a metastatic disease, or you're not sure if it's actually just a benign lesion. And so how do we go about it? So what we can do is we can actually localize these lesions using many techniques, which I'll explain to you in a little bit. So when you're going to localize any lesion, what are the most important things? There are a few pointers we need to know. The first thing is you got to have a high accuracy rate for these lesions. The second thing is it's got to be not so morbid, low morbidity rate, minimal dysplasia to the comfort. You want to make sure it's a short time so they can localize it and it can come out quickly. It must be able to apply to the whole lung field. It must be available in most institutions and minimal equipment required. It of course has to be cost effective. You want to have minimal radiation exposure to both the surgeon or the radiologist. And of course, moving forward to the future is the hybrid OT where you can do everything in a one-stop center place. So how do we do image-guided localization? So how do we localize the lung lesion? So you can either do it through a CT scan method or again through a bronchoscopy method. So it goes back to the same way of how they get a diagnosis. So instead of getting a diagnosis, you actually localize the lesion instead. So CT guided techniques we've got, and this kind of applies to both even bronchoscopic techniques. You can use the dye localization, the methylene blue that is quite commonly used, ICG, hook wire localization, microcoils, which actually I use in my center. And of course, there are other reports of using barium or lipodiol. So dye localization now, methylene blue has reported more than 20, or I would say more than now 30 years right now, and it's got a high success rate. It has a short localization procedure time. It can be easily performed in most centers and has no anatomical limitations. And of course, minimal exposure to radiation. So the surgeon is actually kind of not exposed to the radiation. So disadvantage is that many times I've seen if the lesion is maybe superficial or the radiologist inject the dye superficially, the dye actually goes all over the pleural space instead. So you actually lose the effect of the methylene blue. And the other minor complications that can happen, just like any biopsy, you can get a pneumothorax, you can get intrapulmonary hemorrhage. And of course, what we're worried always about is anaphylactic reaction, but it's really, very rare. So it's an example of a dye localization here, and you can see, so it's very clear cut, you know exactly where the lesion is, and you can go in and wedge the lesion. So the other methods that people have come up with are things like hook wire localization, and hook wire localization was of course adapted from the breast hook wire, and again is very easily placed, and it's cheap and affordable. And so the advantage basically is they have a very accurate localization rate. And surgeons, basically what we do is when we put the VAT scope in, you can see this wire coming right here into that lesion, and then you can just pick it up and place a stapler on it and resect it. Now, one disadvantage I feel about the hook wire is that if it's not placed properly by your radiologist and they place it superficially to the lesion, so Jenny, you may actually amputate the lesion partially also. So this is actually a little bit, you have to use a little bit of your own surgical techniques to be able to make sure that you get under the lesion. And this sometimes can be a bit difficult when it comes to GGOs because they have to place the hook wire posterior to the lesion for you to actually get a good wedge of it. So the other drawbacks basically, and we've seen this in our center, is that when they place the hook wire is still sticking out, so they plaster it down. And sometimes when they turn the patient and they put the lung down, because the wire is still plastered, we forgot to remove the plaster. It kind of, when the lung comes down, it actually pulls it out of place, and so then you lose, or it gets dislodged. The other happens when they actually move the patient. So what most surgeons do is they make a conscious effort, basically, is that when they turn the patient, they're ready to drape, they actually cut the wire off from the skin. So when the lung collapses, the wire comes down with the lung, and you can see it sticking out from the lung through your VAT scope. So complications, again, the same thing. So what I use in my center is microcoils. Why? Because I feel that it's within that patient, there's no risk of dislodgement. And again, it all depends again with hook wire. Sometimes you don't estimate correctly and you take it too superficially, or you don't get the margin. So what we do is we bring the patient to the radiology, they get the coil, and then we bring the patient to theater. So again, they place the platinum coil, and generally you want to put it posterior to the tumor, so then you can get around it. So here's an example of a small lesion here. They put the coil, and you can see the coil is sitting behind the lesion over here. The disadvantage of the coil basically is mainly to the surgeon, is because it's direct radiation exposure to us, and this is something that people are moving away from right now, or we're trying to move away from to enhance to do more better localization without actually having radiation exposure. So sometimes the coils also can migrate, and again back to the same complications as per any CT guided procedure. So this is what I'm talking about. Our setup, you can see here the surgeons over here, and you can see the radiation exposure is I mean, we are gowned up, we are suited up with lead guarded gowns, but there's still a lot of radiation exposure here that we are concerned about. So example of the localization. So just a quick video. This is the lesion that you can see. They put a bit of methylene blue over here, and we can actually see the entry point. And moving forward, we just pick up that area with the bowel grasper or anything you have, and then you can put a ring forceps to roughly guide you where it is over there. Then you take the photo or take the II, and you can see the coil is behind or in front of the ring forceps, and you can just put a stapler underneath there, and you can then just do the wedge resection. Okay, and so then this is what we get. You can see here the coil and the methylene blue also within it to mark the area. So ICG is the new technique everyone's using right now. The ICG is very, very good right now because it's just another type of localization method. But with our enhanced tower stacks, they've got the infrared where we can actually then see the lesion. So I'm not going to talk about ICG localization during a segmentectomy, but more focus on localization for single lesions. So you can see here an example where they injected the dye or the ICG around that area, and we know roughly the lesion will be here, and you can then go ahead and wedge it. So there are many companies that do it. I think there's Skull Stores, there's Olympus, there's Stryker. So I think so far when it comes to ICG, the Stryker unit gives kind of the best appearance of the ICG, but everything still works, and I think all the three companies that make it actually do a good job. So besides doing it via CT scan method, you can also do it via newer ways, bronchoscopic guided techniques, and you can do it one stop actually in the theater, and you can do real-time navigation. So I think Medtronic or Covidien basically has their Super D, and we did attempt it. So what you need to do is you need to calibrate the operating theater to understand where your position is. You must get CT scans that are actually 1 mm cut for them to reconstruct the image onto their Super D system. And just a quick video of how it's done is basically you put your bronchoscope in, and the lesion's over here, and once it gets to a point where the bronchoscope can't go further, then you can actually then release the probe, and the probe then, which has been calibrated with your theater and with the patient, can then navigate us just like a GPS exactly into where the lesion is. And this is your view from the Super D. You can actually see the 3D reconstruction of the airway, and that will tell you turn left, turn right, and you can then get to the lesion, and then you can actually biopsy the lesion. So a lot of cool stuff. Other thing is I've seen Ion by Da Vinci. I've never seen the system, but I just went online and checked it out, and I've seen their promo videos. It's very, very cool. It looks like it's a robot through again the same process where they reconstruct the airway for you, and they tell you where the lesion is, and they literally guide you through, and you're literally like, you know, on the Star Enterprise, or the Star Trek Enterprise, and using all these handheld devices, you can actually just navigate your way through, and either localize or even biopsy the lesion over there. And of course, the Monarch by Oris, yes, also has another robot arm. And same thing, we're all going back to our video game era. I think the new generation of inventors are all video gamers, so you can see they're coming up with all these other cool designs for us to maneuver easily and find your lesion. So what we do nowadays basically is dual localization, where we use both techniques, where we use the methylene blue. I think you've seen in most of my photos, either it's a hook wire with methylene blue, or a coil with methylene blue or ICG. And this is good because this really enhances your ability to localize the lesion and actually resect the lesion completely. Many countries are actually moving to the hybrid theater, where we can then it's like a one-stop shop where you intubate the patient's asleep, and then you can either, using the hybrid OR and the CT arm here, you can either do a percute localization, and you can actually put your coil or inject ICG into the area, or you can even do it via bronchoscopy. You can see here the same way. And then once you localize and confirm the lesion with your CT scan, then you go straight and do a VATS procedure. It's a one-stop center. So the future is basically innovation to more things. And Dr. Toshi Sato is a friend of ours. I think many people know him. He's from Fukuoka University. And I think he designed something like RFID tags. And this is something interesting that we are very keen to try on. And what he does is he uses the bronchoscope to localize the lung lesion. And then he turns the patient over, there's a VATS, and he uses the probe to then isolate the lesion. And so here's an example. He sent, these are his slides, he sent it to me. And a small lesion here that's 6 millimeter in size. He used a bronchoscope to localize the lesion. And you can see this RFID is very, very small. Yeah, let me pause it there. There we go. He put it over there, and the lesion is close to it. And I hope you can hear the noise. So that kind of, yeah, when you hear that tone, you know, you can then confirm the lung is in that lesion and localize it, and then you can resect it. So many cool things coming up in the future. People are innovating more and more, and you can see over here, that's the RFID tag next to the RFID tag next to the lung lesion. And I think that's the future. I think there's more innovations to come, and I think we can actually give better care and treatment for our patients with small lung lesions. With that, thank you.
Thank you, Dr. Harish. Very nice presentation, lots of info. I see a few questions here, which we will discuss at the end of the program. Now I'm going to introduce Professor Mingyon. He is Director of Department of Thoracic Surgical Oncology, Cancer Institute in Japan. Japanese Foundation is also a member of the Japanese Surgical Society and the Japanese Association of Thoracic Surgery. Also a good friend of ASEAN, who's taught well around this region and well respected and liked. The stage is all yours, Professor Moon.
Thank you very much, Dr. Aneez, for kind introduction. I also thanks for the committee of the seats webinar. So I am Dr. Moon from Tokyo. My hospital is a Cancer Institute Hospital, Tokyo, Japan. So today my topic is early stage lung cancer, segmentectomy versus Lobectomy. This slide shows the tumor size of our resected cases. Half century ago, the big tumor more than 3 centimeters was mainly resected, but recently the 3 centimeter or less primary lung cancer was about 80%, and 2 centimeter or less was about 50%. So the indication for minimally invasive surgery are also increasing. This slide shows the history of the segmentectomy. So the first case of segmentectomy for bronchiectasis was reported by Dr. Churchill in 1939, and in Japan, Dr. Kojo reported the first case of the segmentectomy, and Dr. Shiozawa and Arai reported the anatomical segmentectomy. So he's Dr. Arai. He's a legend of our thoracic surgeon society in Japan. So he published the 3D CG like this textbook. So he is now 83 years old, but he has a passion for the anatomical segmentectomy. This slide shows anatomical segmentectomy from these textbooks. So classically, after dividing the segmental bronchus, the intersegmental plane was dissected using a finger, because you know the intersegmental plane is a very loose layer, so you can divide using a finger. But this method is for the indication of benign lung tumor. So recently we indicate the segmentectomy for primary lung cancer metastasis. So the bronchial selection near the tumor is not a controversial method. Regarding the lung cancer surgery, Graham reported the unblocked left pneumonectomy in 1933, and you know, Kehan reported the radical lobectomy in 1960s. Since then, the standard procedure for early skin cancer has been the lobectomy with lymph node dissection, because this lung cancer study group reported the RCT, lobectomy versus limited resection. You know, he's a Kehan. And this is a reported lung cancer study group. In this study, it resulted the local recurrence rate in limited resection group was higher compared to lobectomy group. And 5-year overall survival is inferior in limited resection groups. But their studies have some limitations. One is a big tumor, nearly 3 centimeters, are included in limited resection group. And also the wedge resection also included in limited resection groups. So we need to try to a new randomized control trial. Recently, there are many reports from Japan, the positive data of segmentectomy for selected lung cancer patient. You know, Dr. Okada is a famous one, and he published the Atlas of Segmentectomy like this textbook. This textbook is very useful for our thoracic surgeon in Japan. This slide shows a minimal invasive surgery. There are 2 ways. One is a minimally invasive approach, which includes the complete bats, hybrid bats, and mini thoracotomy, and robotic surgery. And on the other hand, the lung preservation procedure is sublobar resection, which includes a wedge resection and segmentectomy. So segmentectomy done by complete bats is a kind of a minimal invasive surgery. This slide shows a sublobar resection and lobectomy. Sublobar resection includes a wedge resection and segmentectomy. So compared to lobectomy, the segmentectomy, the lung preservation is better after surgery. But segmentectomy is technically a more complicated procedure, because we need to expose the segmental bronchus and artery to the distal side. And we need to confirm the intersegmental plane when we perform the anatomical segmentectomy. And detection of the lesion is sometimes difficult to in segmentectomy, because there are many opportunities to resect the peritoneal lesion. And surgical margin is also inferior compared to lobectomy. And the higher node dissection is also inferior compared to lobectomy. So in my opinion, this is a merit of segmentation. Only lung preservation is better. But these factors are inferior to lobectomy. So we need to accurate selection is important for segmentectomy. So the most important issue of segmentectomy is patient selection. So to do so, we need to know the invasiveness of the tumor preoperatively, and location is also important. You know, this is a pathologic GGN region. How to judge the invasiveness of the tumor using this synchronicity. You know, this is a tumor size including the GGO component. This is a solid consolidation size. You know, consolidation to tumor ratio is most simple indicator of judging of the invasiveness of the tumor. So CT ratio less than 0.5, radiologically GGO dominant region. These regions are almost cases non-invasive cancer such as AIS or MIA. But instead, CT ratio more than 0.5, radiologically invasive cancer. This is the most simple. And recently, the PET CT scan was available for the judging of the invasive of the tumor. Now in Japan, we have 3 trials for peripheral small size lung cancer. This is the most important randomized control study. So the patient with the tumor, 2 centimeter or less tumor, whose consolidation to tumor ratio 0.5 to 1, radiologically invasive lung cancer. We try to now lobectomy versus segmentectomy. This is a randomized control study. And 2 centimeter or less, whose CT ratio less than 0.25, radiologically non-invasive lung cancer. We have one-arm wedge resection study like this. And this area is a one-arm segmentectomy study. So now in Japan, we have 3 trials for small size lung cancer. So our intentional indication of segmentectomy is this red area. Basically, I indicate a segmentectomy for non-invasive cases. And the compromise indication is here, so which includes a high-risk patient, includes the octogenarian and primary reserve and study cases. This is here is our compromise indication. And this compromise indication cases, we adapted the segmentectomy for the invasive case. So we need to do mediastinal lymph dissection. And this is a preoperative synthesis CT. Before we confirm each structure like this slide, this is the B2B, B2A, and V2B, and so on. And we make a virtual intersegmental plane in my head, and we need to judge the surgical margin using this synchronicity. But recently, we can use a 3D reconstruction sheet. This is a Synapse Vincent made by Fujifilm Corporation, Tokyo, Japan. So we can easily make a 3D reconstruction like this. So you can see this is a tumor. So if I click the A8 and A9 branch, so I can make a 3D virtual intersegmental plane like this. In addition, in this workstation, we can measure the surgical margin from the tumor to the closest intersegmental plane. So now we can easily decide the surgical procedure. We can do the segmentectomy only. We need to do the segmentectomy in conjunction with segmentectomy, or we need to do the lobectomy. It's very simple. The detection of the tumor during the operation is important. As Dr. Harish said, preoperative marking method, there are many methods reported, but I think that this marking method is invasive for the patient and time-consuming and expensive sometimes. I usually use my finger through a small incision, maybe the 2 centimeter, I can use my finger to palpate the tumor. This is non-invasive for the patient and quick and cheap procedure. So management of segmental artery and bronchi is important. So 2 millimeter or less segmental artery are usually divided using energy devices. And 2 to 5 millimeter are usually divided after ligation. And 5 millimeter or more, I basically use a stapler to divide. And the management of the intersegmental brain is also important. In my opinion, for GGO reason or small metastasis, I sometimes preserve the intersegmental brain to perform the anatomical segmentectomy. But for invasive cancer or large size metastasis, intersegmental vein is maybe a drainage vein of malignant cells. So I usually divide the intersegmental vein from the oncological aspect. And detection of the intersegmental brain is also important. There are two ways. One is using segmental bronchus, and another is using segmental arteries. And jet ventilation method is most famous in Japan. This because this method is reported by Dr. Okada, Hiroshima University in Japan. So he used a bronchoscope to inflate the target segment. So he can make an inflation-deflation line like this. So he divided this borderline using a 100-watt cautery. So it's very dangerous for me. But in this technique is sometimes difficult for the patient with emphysema like this. So in this particular patient, the border is not so clear. And I divided the intersegmental plane using a cautery, but I don't know where is correct the intersegmental plane. So it is sometimes difficult to identify. So this report is reported by Dr. Oizumi from Yamagata University in Japan. So he used a slip knot to close the segmental bronchus. After totally inflating, he clamped the target segment using a slip knot, and then the lung is deflated. So the target segment is inflated, and the residual segment is collapsed. So he can make intersegmental plane like this. This is one procedure. But this is time consuming, so I don't like this procedure because I am a short temper. This is a slip knot technique. And there are some reports using needle inflation and ICG injection from the target bronchus. And this is using segmental bronchus techniques. So now I use ICG fluorescence navigation. So this technique is firstly reported Dr. Misaki from Kagawa University in Japan. So he used a prototype of IRT. So after dividing the segmental artery and bronchus, and ICG injected intravenously. So the dark area is the target segment, and the residual segments are lighted like this. So he put some mark around this border. So in this paper, he confirms this marking continued to the intersegmental structure by macroscopic examination. So this border is a really correct intersegmental border. Now I use this ICG fluorescence method. This method is very quick and easy technique. But we need the cost because this IRT system is a little bit expensive. There are some companies produce infrared thoracoscopy, Strauss Spice System, Striker, and Olympus. And in addition, we can use this system in robotic surgery. Robotic Da Vinci Xi can be used this ICG technique. And near the high lung, I usually perform the bone dissection, and peripheral lung, I usually divide the lung by stapler, and sometimes using the energy devices. So the tip of the stapler is almost 1 centimeter. So when I want to decide the keep the surgical margin, I sometimes use electrocautery cutting. It depends on the case. This is a result of our segmentectomy cases from 2008 to 2016. We have 191 cases. In these cases, compromise indication was included 24%. and almost cases are adeno. And the upstaging was seen in 6 patients. These 6 patients is in the compromised indication group. And we experience many various kinds of segmentectomy, including subsegmentectomy. So ICG navigation was done in 41%, and operation time was 170 minutes, and blast loss was 42. The conversion was 1 cases because of the PA bleeding. In this case, blood loss was about 3 liters. It's very life-threatening, but the patient is healthy now. Chest drainage was 1 day, and hospital stay was 7 days. Mobility was 10%, and mortality was 0. This is slide shows the Kaplan-Meier curve. So the 5-year OS was 93%, and 5-year RFS was 91%. During this period, so 9 patients died. 1 for lung cancer and 8 for other disease. And we have 4 recurrences. All recurrence distant metastasis, brain metastasis and bone metastasis in 1 patient, and pulmonary metastasis in 3 patients. But these 4 patients classified in the compromised indication cases. You know, this is a major randomized control study of limited resection. One is a CARD-B study, and one is a Jacob 0822 study. So you need to know the difference of these 2 studies. So in CARD study, the patient was included non-small cell lung cancer without PRGGN region, but Jacob study including the non-small cell lung cancer without non-invasive lung cancer on Shinsuya CT. So CARD-B studies, sometimes patient with consolidation to tumor ratio 0.25 to 0.5 are included. These patients have a part of the non-invasive cases. The study design was non-inferiority trial, and standard arm is Lobectomy. And investigation arm is in CARD study include a wedge resection, but Jacob study is a segmentectomy only, and this is different. And primary endpoint was OS, and the secondary endpoint is post-operative pulmonary function. So in case with the surgical outcomes of segmentectomy is not inferior compared to lobectomy, and post-operative pulmonary function is better in segmentectomy. In such situations, so the segmentectomy may become a standard procedure for selected early-stage lung cancer. So the selection is depend on you. Our surgeon selects the segmentectomy. So proper selection is important. Now, totally we have 1,000 and more than 1,000 cases are enrolled. And this result will be reported this autumn. So we are waiting this result. So this is my last slide. So after the segmentectomy, we sometimes the tumor occurred at the cutting edge like this. And both patients are the PET scan positive. So we are afraid of the local recurrence, but these cases granuloma by bronchoscopic examination. So we sometimes experience a granuloma occurring at the cutting edge like this. So at the recurrence of the cutting edge, we sometimes perform the compression lobectomy after segmentectomy, but it's a quite difficult procedure. So the indication is the most important. Compared to regarding lobectomy, so when we divide the fissure, there are no branches of the bronchi in the fissure. So we have no experience of in this situation of the after lobectomy. So this is a difference. We sometimes experience segmentectomy, this phenomenon. this is my take-home message. Maybe you now stay home. The patient selection and the higher node dissection obtain the surgical margin in segmentectomy are more complicated than those in lobectomy. But each procedure in segmentectomy is the same as that in lobectomy. However, we need to evaluate the dissect each structure toward more peripheral site. And there are many reports of local recurrence after segmentectomy, so we need to wait for the result of the large scale randomized control study before we indicate the segmentectomy intentionally for the patient with radiological invasive bladder cancer. Thank you very much.
All right. Thank you, Professor Mun.
Yeah.
Very nice talk. We have some questions. This is from Rubon. I think both of you can take this question one by one. Have you encountered a scenario what are the scenarios you encounter where you perform a lobectomy straight before obtaining a histological diagnosis? Harish, you want to go first?
Okay, sure. So I think generally, most of the time, it comes down to the basic thing. You got to take a proper history of the patient. You got to look at the radiological scan. And if you actually kind of see a very speculated lesion, you know, I generally sometimes very clear cut, I would just offer the patient a lobectomy. In most cases, tumors that are very big, more than 3 centimeter lesions, again, like you said, like I mentioned earlier, you're doing actually, even if it's a large infective lesion and you're not sure whether this is a cancer and they biopsied it a few times, I would actually just perform a lobectomy straight away for the patient. The most important thing is that you actually have a clear understanding, or you clearly tell the patient what your intentions are to do and what the reason of doing a lobectomy for. I think that's the most important thing, that once you explain that to the patient and you come to an understanding, that's when you go ahead. But small lesions under 1 centimeter, you know, I generally won't do a lobectomy for those patients without a biopsy.
Dr. Mohan?
Yeah. So I think the small size tumor is difficult to get a diagnosis preoperatively. So in the case is more for PRGG region, more than 15 millimeters. So of course I follow up at least 3 months, but the GGN region it doesn't disappear. So we recommend it for the patient, segmentectomy or lobectomy without diagnosis. Yeah, it's case of case. Some patients want to be resected, but some patients deny the surgical resection. It depends on the surgeon's willingness.
Okay. So to answer your question, Rubon, is that you inform the patient what you're going to do beforehand. And if you think it's a central lesion, it's reasonably large, and you have a doubt that it is going to be cancer, then you resect it as a thing. Okay, so there's a question here for Dr. Harish. It says, this from Ingxiang. Thanks for your detailed talk. At times you have excessive spillage with ICG localization. May I know the dose you use?
Okay, so when we first started using ICG, this is a common thing. You know, we started off with 2 ml and the whole lung lights up instead. And so I actually spoke to Dr. Chow in Taiwan about this, and the doses are actually very, very little. So I only give about 0.5 ml if you're localizing the lesion, and that won't disseminate so much. That's number one. The second thing is that your radiologist should not inject it superficially. Now, there's a high chance every time they inject it superficially, as they're injecting, they pull it out some more and they inject some more. And that causes the spillage in the whole pleura. So we actually have to tell them, once it goes in, just inject everything into that local area and come out. Don't inject and pull back out, because it always causes that spillage issue.
Yeah, I think I agree with Harish, but if you place the tip of the needle in the so-called lesion, then the spillage doesn't occur. The problem is if you start to inject around it, and then you'll have more spillage.
Yes.
Another question from Ingxiang to Dr. Mun. I think this is a very good question. It says, thank you, Dr. Mun. Can I ask your intra-op approach to nodal sampling during sublobar surgery? What level do you send for frozen section? And if positive, do you convert to a lobectomy?
Yeah, of course, I convert to the lobectomy if frozen section positive nodes, because even now the standard procedure is a lobectomy with lymph node dissection. So if I confirm the N1 cases, we convert the lobectomy for our intentional indication cases, but the compromised indication cases, we cannot do the lobectomy because of the patient lung preservation. So in such case, we finish the segmentectomy with lymph node dissection. But there are a few cases, 2 or 3 cases, pathologically node positive cases. But these cases, fortunately, there are no local recurrence at the higher nodes.
I saw a couple of cases in your trial which were like 2B, 3A. Were they pre-planned segmentectomy or they were incidental segmentectomies?
Yeah, maybe I selected the segmentectomy. Yeah.
Because of poor lung function?
Yeah. Yeah.
All right. Okay. Any other questions I have here? Yes. Dr. Harish, the tables which you used for carrying out a risk calculator for your GGOs, do you use them in your practical life? Do you really use that to create?
The reality is that no, I don't use it. And it kind of moves with a bit more experience. I think the more you follow up the lesions, the more CT scans to review. And in Singapore practice, generally, we're actually quite aggressive with our management of GGOs. So anything more than 8 millimeters, generally, we become more invasive with them and we don't follow them up, but we actually recommend a surgical biopsy unless the patient really doesn't want it. I think the Brock's calculator is a great way to tell its probability, but at the end of the day, it's a theoretical calculator. And I think a lot of times these calculators can be wrong. So you need to have a clinical indication to go in. And I think you should use your clinical knowledge to do so.
Yeah, that question was from a colleague from Vietnam. For further info, you can actually go to the internet and you will be able to get information on the calculators, which are downloadable. Question to Dr. Mun.
Yeah.
How do you reconstruct your segmental anatomy? What kind of software do you use?
Yeah, software, I usually Synapse Vincent.
Synapse.
Yeah, Synapse.
Synapse. That's from Fuji, right?
Yeah, Fuji. Fujifilm Corporation. Yeah.
All right.
Dr. Mun, can I ask you a question?
Yeah.
For very small lesions,
yeah.
And after you reconstruct with the Fuji device system,
yeah.
has there been a time that when you do remove it, the lesion is not present?
Yeah. Yeah, I never cases.
You didn't have a case, okay.
Yeah, so the planning of the segmentectomy is the most important to do segmentectomy. So, of course, the very, very deep region, so we recommend it for the patient to perform a lobectomy. Yes, so it's very, very difficult to palpate during the surgery. And sometimes we take out the resected specimen. So in the specimen, we sometimes confuse that and realize the tumor for PRGG region. So in such cases, we select the SBRT or lobectomy by BATS.
Okay. I have one more question. I think segmentectomies, at least from my experience, are very good for superior segments or just doing one segment in the upper lobe. But when it comes to things like middle lobe or coming to removing 2 segments in the upper lobe, say right upper lobe, I mean, I've seen some surgeons say, oh, I preserve the S2 segment. And I always question, I said, why do you do that? Especially if the patient has a very good lung function.
Yeah, so I think I tried middle lobectomy, so a segmental force segmentectomy is not suitable for me. So because the middle lobe is very small, so I try to I recommend it for the patient for segment lobectomy. Yeah.
And what about for the right upper lobe? Do you take 2 out of 3 segments?
I sometimes perform the only 1 segment. the two segment is more is a little bit confused, and the residual segment is very small. So
yes, exactly.
yeah, yeah, I think that there are no merit of by segmentectomy.
Yes, okay,
Yeah.
thank you.
Question from Dr. Padunkiat to Dr. Harish. It says, in a patient who's already had previous lung cancer resected, would you follow up the GGOs differently? Let's say patient
yes.
or pure GGO.
Yeah. So we actually see this a lot in Singapore. So we see a lot of patients, especially never smoker females, Asians, they get multiple GGOs. So we do a surgery, a segment or a lobectomy for one side, and you find out it's very early stage lung cancer or lipidic cancer. And then you repeat a scan again, maybe a year or 2 years later, and you see a GGO on the opposite lung. So I tend to tell the patient that there's always a possibility of this being a cancer. I would do a much more closer CT scan. So I'll review them in 4 months earlier. And again, I'll follow the simple steps. If the lesion is actually enlarging or becoming more solid, then I'll go ahead and plan a resection for them.
Okay, so for GGO surveillance, do you routinely use contrast enhanced CT or just HRCT non-contrasted? Question from Gerard Lopez.
I would actually, all my patients have a contrast CT scan. Unless contraindicated, then I'll get a HRCT, but most of the time I always get a contrasted scan.
Do you differ, Dr. Mun?
Yeah. So I follow up using the non-contrast enhanced CT because the solid region is easy to the non-contrast enhanced CT. It's very okay. So when I use a contrast CT, so we evaluate the higher nodes and the medial lymph nodes. In such cases, we need to evaluate the lymph node. We use a contrast enhanced CT.
I think in real life, the GGOs are picked up when they have a screening scan, which is low dose non-contrast.
Yeah.
When you're going to follow them up, I think you're going to ask for a 1 mm cut HRCT with contrast.
Yeah, yeah.
You'll have better definition. I think that's how life is. Okay, gentlemen, I think we have to call it quits for today. Okay. I thank Dr. Harish and Dr. Mun for excellent presentations, and audience have been very actively participating in questions. I have a lot of chatter going around. Okay. All right. And gentlemen, thank you very much. Stay safe. Stay free from COVID. Yeah.
Thank you. Have a good night, everybody. All right.
Good night.
Bye-bye.
Good night.
Bye.